Welcome. In this last session on pre-chiasmal lesions, we will be discussing hereditary, toxic, traumatic, optic neuropathies as well as certain anomalies like optic disc drusen and other congenital anomalies. Hereditary optic neuropathies as well as toxic and nutritional deficiency optic neuropathies have certain common characteristics. The final common pathway of these optic neuropathies are through the mitochondrial energy metabolism pathway. As a result, there is reduced ATP generation as well as increased production of reactive oxygen species. Both these factors result in the neuronal damage. All these types of optic neuropathies preferentially involve the papillomacular bundle. This is important to remember. Since the papillomacular bundle is involved, we get temporal disc pallor, but the disc appearance may not corroborate with the severity of the loss of visual acuity, the color vision loss and the visual field defects. We get a centrocecal scotoma. This is also important characteristic of hereditary and toxic optic neuropathies. A centrocecal scotoma extends from the blind spot towards the fixation. So this is a picture of the right eye visual field, and we have the blind spot here representing the optic disc, and a centrocecal scotoma extends from the blind spot nasally to involve the fixation, but it does not respect the vertical meridian, as we will see, which happens in post-chiasmal lesions. Pupillary reactions may be normal. Leber's hereditary optic neuropathy or LHON results from mitochondrial DNA point mutations, and there are several loci which have been identified. We have the 11778, the most common, the 3460 and the 14484 positions. The first two mutations have more severe visual loss than the third. Being a mitochondrial mutation, LHON is inherited only from the mother, but females are affected much less than males. 80 to 90% of LHON patients are males. Most symptomatic patients have homoplasmic mitochondrial mutation, which means that all their mitochondria have the mutation. And LHON has variable expressivity. Males with affected mitochondria are generally symptomatic but may be asymptomatic, whereas females with affected mitochondria are frequently asymptomatic. The usual age of onset is 15 to 35 years. LHON characteristically presents with an acute visual loss which is painless and sequential. So sequential is a very important term for LHON, that is, the two eyes are not involved simultaneously. One eye is affected followed by another, and there may be a gap of weeks to months between the two eyes, and the visual loss is severe. The patient may describe it as a central or generalized blurring. Pupillary reactions may be normal even in the monocular stage when one eye is affected and the other eye is yet to become affected. Ophthalmoscopically, we will find a hyperemic disc which appears edematous but does not leak on FFA. So this is another pseudoedema. We have a hyperemic disc without leakage from the disc. We find peripapillary telangiectasia, which occurs only in the early stages and later on disappears, and tortuosity of arterioles are also found, and they appear only in the early stages. Later, the disc shows temporal pallor. The disc signs may precede symptoms, and if the early signs of hyperemia, peripapillary telangiectasia and arteriolar tortuosity disappear, the disc may appear normal at presentation. Recently, OCT has been shown to be important for LHON, which we have discussed in detail in the presentation on OCT. Visual field analysis reveals central and secocentral defects, and with the help of the OCT we can now identify a subclinical or a pre-symptomatic phase. In carriers with the mitochondrial mutation, the subclinical phase before the symptom onset may be detected on OCT by pRNFL thickening in the temporal quadrant, and this may help to institute treatment in an even earlier stage. So if the patient is known to have a family history of LHON, we can do serial OCT to pick up the disease in the pre-symptomatic or subclinical phase. So we diagnose LHON by mitochondrial DNA analysis, and treatment, there is no definitive treatment yet for LHON. However, ID be known which is a coenzyme Q10 analog and a free radical scavenger, may be helpful in the early stages. However, it requires long-term administration, and the LHON patients are advised to avoid tobacco alcohol intake, which may stress the mitochondria, as we will later see. Gene therapy is under trial. So what is the prognosis of LHON? 65% of those with 14484 mutation show late improvement in central visual function. However, very few, only 4% with the most common 11778 mutation show improvement. Coming to the next hereditary optic neuropathy, autosomal dominant optic neuropathy or ADOA. It is the most common hereditary optic neuropathy. It is dominantly inherited with variable penetrance and expressivity, and several gene mutations have been identified. OPA1 gene, which through encoding dylamine is associated with integrity of the mitochondrial membranes. OPA3 gene has also been identified, and it is also related to mitochondrial function. Onset is earlier in the first decade of life. ADOA has insidious onset, a slowly progressive clinical course, and symmetrical loss of vision in either eye, and the visual acuity rarely goes below 6/60. So in contrast to LHON, which has a sudden severe loss of vision and a sequential loss of vision in either eye. ADOA shows blue yellow color deficiency, and they thus may pass Ishihara test, and we may fail to detect ADOA through Ishihara test. Centrocecal visual field defect is found. An optic disc shows focal wedge-shaped area of temporal excavation and pallor. So this terminology wedge-shaped is important for ADOA. And OCT we have discussed in the presentation on OCT. Commercial genetic testing do not analyze all possible mutations responsible for ADOA, and neuroimaging is indicated to rule out other possible etiologies of optic atrophy, and there is no definitive treatment yet for ADOA. There are other genetic disorders associated with optic atrophy, but in these the optic atrophy is associated with other non-ophthalmologic systemic signs and symptoms such as Deadwood syndrome, hereditary ataxias, and Bird syndrome. Coming to toxic and nutritional deficiency optic neuropathy, they are usually insidious in onset and slowly progressive, as well as bilaterally symmetric. However, methanol and ethylene glycol toxicity presents with sudden loss of vision and acute loss of vision. The earliest manifestation is a reduced visual sensitivity within the central 10 degrees of the visual field, which can be detected with automated perimetry and multifocal ERG. Later, the visual acuity declines with color vision defects and central or secocentral scotoma. Disc pallor occurs eventually. Methanol poisoning, however, may present with early ONH edema. So neuroimaging should be done to exclude other etiologies. OCT is important for patients on drugs which are known to cause toxic optic neuropathy, and OCT may help us to pick up drug toxicities early, and serum and urine analysis can help us detect both toxicity and nutritional deficiency. So in toxic and nutritional deficiency optic neuropathy, if the toxic agent can be removed or nutrition supplemented before optic atrophy sets in, potential for visual recovery is good. However, the visual recovery takes a long time to happen. Vitamin B12 cyanocobalamin may help in tobacco alcohol amblyopia and is often given in these patients. So there are a large number of agents which may cause toxic or nutritional deficiency optic neuropathy, and going through them quickly. Toxicity can be caused by methanol, ethylene glycol, organic solvents, carbon monoxide, lead, particularly in children, cyanide, smoking, mainly cigarettes, ethambutol very important, chloramphenicol important, amiodarone may cause ONH edema and appear like non-arthritic AION, vincristine, cisplatin, linezolid, ciprofloxacin, infliximab, etanercept, adalimumab, and disulfiram. Drugs causing NAION or making the disc appear like NAION include amiodarone, phosphodiesterase 5 inhibitors, and interferon alpha. Nutritional deficiency of vitamin B1, vitamin B12, folate, homocysteine, methionine, and copper may cause nutritional deficiency optic neuropathy, and vitamin B1 deficiency, also known as Wernicke's encephalopathy may be lethal and needs to be suspected early and treatment initiated. And nutritional deficiency optic neuropathy can also occur with alcohol abuse, bariatric surgery and colectomy. And a differential diagnosis includes lesions involving a prefixed chiasm with bitemporal hemianopia in a psychocentral pattern. That is because in a prefixed chiasm, the posteriorly located macular fibers are affected more with a lesion in the region of the sella turcica. Bilateral optic neuritis is also in the differential diagnosis, and psychogenic visual loss must also be excluded. Coming to traumatic optic neuropathy, we have a direct type of traumatic optic neuropathy and an indirect type of traumatic optic neuropathy. Direct traumatic optic neuropathy is less common than indirect traumatic optic neuropathy, and direct traumatic optic neuropathy is caused by direct impact on the nerve. And this direct impact on the nerve can be due to the injury causing agent itself or from bone fragments, foreign bodies, or intraorbital and intrasheath hemorrhage. An HRCT is indicated in such a traumatic situation, followed by surgical management as required, and the prognosis is guarded. Indirect traumatic optic neuropathy is caused by an impact on the forehead or the maxilla, and this impact may be relatively minor. So impact on the forehead is important to remember for indirect traumatic optic neuropathy. As a result of this impact, there are shearing forces which are generated in the optic canal, and this leads to damage to the pial vascular supply of the nerve. The shearing forces are generated because the optic nerve sheath is tightly adherent to the lining of the optic canal. This primary injury, the shearing force and the subsequent interruption of the pial vascular supply to the nerve is not treatable. Secondary edema and hemorrhage within the optic canal may contribute by causing further vascular compromise. Another mechanism of indirect TON is trauma-induced brain movement, which causes the falciform dural fold, which lies just above the intracranial portion of the optic nerve, to impact on that portion of the optic nerve. Indirect traumatic optic neuropathy results in an immediate and severe visual loss, and the visual loss may be no light perception in 25 to 80% of patients. RAPD is present, and the disc appears initially normal because the impact is far away from the optic nerve head, but becomes atrophic 6 to 8 weeks later. External and imaging evidence of injury may be scarce or absent. There is no benefit of intravenous steroids or optic canal decompression, which has been found in the International Optic Nerve Trauma Trial. We should not confuse this with ION-DT trial, which was for non-arthritic ischemic optic neuropathy. However, the CRASH trial found that there was a higher mortality with intravenous steroids because of the associated significant head injury. Rarely a severe injury may cause optic nerve head avulsion, characterized by a deep pit and hemorrhage at the site of the optic nerve head along with central retinal artery occlusion. I could not find a non-copyrighted image, so please look up on the internet for an image of optic nerve head avulsion. Coming to other disc anomalies, starting with optic disc drusen. Optic disc drusens are refractile and often calcified bodies lying within the optic nerve head, and they are considered to be products of deteriorating axons. It rarely affects non-whites, can be dominantly inherited, and it is often bilateral but usually asymmetric, and it may be associated with retinitis pigmentosa and pseudoxanthoma elasticum. So patients with optic nerve drusens rarely have decline in visual acuity, may have transient visual obscurations, and the disc on ophthalmoscopy is usually small and appears elevated, and the elevation is often irregular. The margins of the discs are also irregular, with or without blurring of these margins, and the retinal blood vessels are not obscured at the margin of the disc. So there is no obscuration of the retinal blood vessels at the margin of the disc, a very important differentiating feature from optic nerve head edema, as we have seen on the presentation on papilledema. The retinal blood vessels may also have anomalous branching, and there is no hyperemia or dilatation of surface blood vessels, which is also found in most situations with optic nerve head edema. Isolated localized retinal nerve fiber layer defects are found on perimetry and OCT. And early in life, the drusens are located more posteriorly in the optic nerve and later migrate anteriorly towards the surface of the optic nerve head, and they appear as refractile whitish yellow bodies, usually with scalloped margins at the margin of the disc. Occasionally they are located outside the disc, and they may have rare complications such as hemorrhages, non-arthritic ischemic optic neuropathy, and peripapillary subretinal neovascular membrane. Imaging characteristics of optic disc drusen are very important to remember to differentiate it from disc edema. On B-scan ultrasound, we find high echogenicity at the optic nerve head, and this high echogenicity is maintained even when the gain of the ultrasound waves is reduced. We find autofluorescence when the drusens are on or near the disc surface. However, fundus fluorescent angiography shows no leakage from the disc. A CT scan shows a radio-opaque signal at the junction of the eyeball and the optic nerve. OCT may show a hyporeflective mass at optic nerve head. In the differential diagnosis of optic disc drusen, we have refractile bodies which are found in chronic papilledema. However, these refractile bodies of chronic papilledema are smaller, occurs outside the disc near the temporal margin, and disappears with resolution of the disc edema, so they do not persist when the disc edema resolves. We also have astrocytic hamartomas as a differential of optic disc drusen, but these astrocytic hamartomas are usually peripapillary and they obscure retinal blood vessels, unlike optic disc drusen, and they do not show autofluorescence, unlike optic disc drusen as well. Coming to the other congenital abnormalities of optic nerve head, optic nerve hypoplasia is the most common congenital abnormality of the optic nerve head, and it occurs due to a reduced number of nerve fiber axons. While the mesodermal and the glial tissue, the supporting tissue, remain normal. It may be unilateral or bilateral, and if it is bilateral, is often asymmetric. The visual acuity may be normal, or it may be no light perception even. In optic nerve hypoplasia, the disc appears small and may be pale or hyperemic, and the distance from the disc to the foveal center is 3 times or more than the disc diameter. In a normal fundus, the distance of the foveal center from the center of the disc is 2.5 times the disc diameter or less. But in optic nerve hypoplasia, we find that this distance appears 3 times the disc diameter or more. Vessel diameters may appear large compared to the relatively small disc, along with tortuosity. We also find a yellowish white ring around the actual disc, and this represents the retina layering over the exposed lamina cribrosa, and this may be a cause for misdiagnosis. And this yellow ring may be surrounded by another ring of hypo or hyperpigmentation, and then it is called the double ring sign. Associations of optic nerve hypoplasia include maternal intake of teratogens such as alcohol, anticonvulsants, and quinine. Maternal diabetes mellitus may cause superior segmental hypoplasia, and septo-optic dysplasia is an association of optic nerve hypoplasia with absent septum pellucidum. Septum pellucidum is the membrane separating the 2 lateral ventricles with a hypoplastic corpus callosum. Septo-optic dysplasia, if it is associated with pituitary dysfunction, it is called the Morse's syndrome, and other CNS abnormalities may coexist. Pituitary abnormalities can be associated with optic nerve hypoplasia, in which case we find that the infundibulum, the connection between the hypothalamus and the pituitary, is absent, and the posterior pituitary is ectopic. This leads to panhypopituitarism with low levels of thyroid hormones, cortisol, and ADOA, and this panhypopituitarism may be life-threatening. Hyperprolactinemia may also be there. So in optic nerve hypoplasia, we have to do an MRI of brain, and also we should monitor the pituitary hormones. Congenitally tilted optic nerve is usually bilateral, and there is excavation of the inferonasal quadrant of the optic nerve head and the adjacent RPE and the choroid. This excavation is often called conus, and there may be an inferior crescent. The disc thus appears to be oval with the long axis oblique or horizontal. Congenitally tilted optic nerve head should not be confused with tilted disc in a myopic eye. With a tilted disc in a myopic eye, we find the crescent most prominent temporally. Because of this inferonasal excavation, there is myopic astigmatism and nasalization of the central retinal blood vessels. The superior pole of the disc may appear elevated. They usually have bilateral superotemporal field defects because of the inferonasal location of the excavation, and they thus resemble chiasmal lesions but not respecting vertical midline. The visual field defect is correctable with refraction. They may be associated with congenital stationary night blindness. Optic nerve pit is usually unilateral, and it is caused by a posterior herniation of the dysplastic retina through a defect in the lamina cribrosa in a collagen line pocket, often communicating with the subarachnoid space posteriorly. It appears as a round or oval localized depression on the optic nerve head surface, and they appear white, yellow or grey, usually in the inferotemporal sector of the optic nerve head. Optic nerve pits are associated with cilioretinal arteries originating from the pit. They may have localized visual field defects, most commonly paracentral arcuate defects continuous with an enlarged blind spot. More importantly, they may have serous macular detachments or retinoschisis. Around 45% of patients with optic nerve pits may have these detachments. They are however not associated with choroidal or iris colobomas, and they do not require neuroimaging. Optic nerve coloboma results from incomplete closure of the embryonic fissure, and they can be unilateral or bilateral. It appears as a sharply demarcated and glistening white excavation within the inferonasal portion of the disc. The functional disc tissue is present superior to the excavation. When mild, it may mimic a glaucomatous disc, and when extensive, there is an enlargement of the peripapillary area with a central excavation lined by whitish tissue on the surface. The blood vessels are arranged along the walls of this tissue. When the excavation involves the entire disc, the inferior portion of the excavation appears deeper. Colobomas have a large number of associations, and optic nerve head colobomas may be associated with choroidal and iris colobomas. Systemic association includes Chart syndrome, Golden Heart syndrome, and Walker-Warburg syndrome. Coloboma with papillorenal syndrome is called renal coloboma, and here the optic nerve head has a central excavation, absence of central retinal blood vessel, but presence of multiple cilioretinal vessels emanating from the optic nerve head edge, and it is associated with PAX2 mutation. Morning glory disc anomaly is typically unilateral and is more common in females. There is a funnel-shaped staphylomatous excavation of the posterior fundus which incorporates the ONH. So the ONH lies within the excavation of the fundus. Alternatively and less commonly, the excavation may be within the disc, similar to an optic disc coloboma, but it can be differentiated from optic disc coloboma because of the straight radial vessels, which happens with morning glory disc anomaly. The ONH is enlarged, appears as pink or orange, and is either recessed or elevated at the base of the excavation. The excavation is surrounded by an elevated area of irregular chorioretinal hyperpigmentation, and there is a white glial tissue on the surface of the center of the nerve. The characteristics of retinal vessels in morning glory disc anomaly is very important and help to differentiate morning glory disc anomaly from other congenital anomalies of the optic disc. The retinal vessels are more numerous than normal, which emanate radially from the optic nerve head margin and appear straight and branch at more acute angles. So we find many vessels, but the vessels emanate straight and radially from the margin of the optic nerve head. Visual acuity is usually moderately affected but can range from normal to no light perception, and RAPD may be present. 1/3 of patients have non-rhegmatogenous retinal detachment, and choroidal neovascular membrane may also occur. However, morning glory disc anomaly is not associated with choroidal and or iris coloboma. Transphenodal encephalocele is an important association of morning glory disc anomaly which should be remembered, and it is commonly associated with panhypopituitarism. Other associations of morning glory disc anomaly include hypoplasia of ipsilateral intracranial vasculature. There is a face syndrome with posterior fossa anomalies, hemangiomas, arterial lesions, cardiac and eye anomalies. We may also have carotid circulation disorders like moya disease. So a patient with morning glory disc anomaly should undergo an MRI evaluation. Myelinated nerve fiber is an abnormal myelination of ganglion cell axons anterior to lamina cribrosa, and we know that myelination normally stops anteriorly at lamina cribrosa. It appears as a whitish area on the retina, and this whitish area has striations along the normal orientation of the ganglion cell axons. Retinal blood vessels are obscured, and these areas of myelinated nerve fiber are usually adjacent to the ONH, but discontinuous and multiple lesions may occur and are occasionally found. What is important is myelinated nerve fiber leads to absolute scotoma in the area of myelination. So lesions such as these must be excluded when we find abnormalities in the visual field report. Also, myelinated nerve fiber may be associated with high myopia and foveal hypoplasia. Aicardi syndrome is an X-linked dominant disorder lethal in males, and we find multiple depigmented chorioretinal lacunae surrounding the disc. Other anomalies of the optic nerve head include Bergmeister papilla, which is a prepapillary glial remnant of the developmental hyaloid artery, megalopapilla, which are bilateral large discs with large cup and may be mistaken for glaucoma. However, in megalopapilla, the optic cup is round or horizontally oval, unlike in glaucoma where we find notching and vertical extension of the cup. Megalopapilla may also have an enlarged blind spot. Optic nerve aplasia is a very rare anomaly where there is absence of optic nerve axons as well as the retinal blood vessels, while choroidal vasculature appears very prominent. When bilateral, it is associated with CNS abnormalities. Melanocytomas are occasionally seen, and they are benign darkly pigmented tumor on the optic nerve head and peripapillary retina with a fimbriated margin. We end this session by listing the characteristics that differentiate glaucoma from other optic neuropathies. In glaucoma, the loss of central visual acuity occurs very late in the disease process. Color vision is preserved, RAPT is generally not found, and the cupping is characteristic with thinning of the neuroretinal rim. However, the neuroretinal rim is not pale. So this lack of pallor of neuroretinal rim is a very important differentiating feature of glaucoma from other optic neuropathies. Thank you for listening.